Hi everyone, welcome to this latest edition of Psychedelics Past, Presents, and Futures, an ongoing workshop that's co-organized by me, Lucas Rickert, and also Liz Burkhauser. It's really a pleasure to have you with us in person and online. Before I introduce our speaker, I wanted to just say quickly that we have another upcoming event, which is April 21st. It's called Plants for the Apocalypse. It's going to be held at DC Greenhouse from 3:30 till 5. And this is an in-person event only. And it's a chance to sort of learn about psychoactive plants and how plants fit in with, death and all the other things you associate with the apocalypse. So if you're able and willing to just show up in person in Madison, love to have you there. What we're going to hear about today, though, which I'm very excited about, is ketamine. And it's our pleasure to welcome Dr. Jason Perepelkin here from the University of Saskatchewan. Thanks for making the trip from Saskatoon all the way here. It's great to have you give not just one, but two talks. And it's great that you're going to be sharing some of your research. Dr. Perepelkin is an associate professor in the College of Pharmacy and Nutrition at the University of Saskatchewan. He's also an associate member of the Edwards School of Business in the Department of Management and Marketing. And he has a variety of research interests, including burnout, fatigue, occupational dynamics of the pharmacy profession, various aspects, but also what he'll be speaking about today, which is ketamine. And I don't want to go on too long. I want to turn the mic over to you, but just wanted to thank you again for being here.
Thanks for having me. Don't clap yet, because I haven't done anything. So thanks for having me and for listening. And if you think I have a monotone voice and it's the recording, it's not. I have a monotone voice. Most of the time I've tried to change it. It's not that I'm not excited, it's just that's the way it is. So today I'll be talking about a study that I did on ketamine and users' experience with that. But first I just wanted to, I'll go over kind of where I'm from, just in case some of you don't know where that is, where Luke is from. And then just look at major depressive disorder, and then kind of look at a summary of its uses, and then review a study that we did, and then what role pharmacists could play in that, the use of ketamine, and also review a patient information booklet that we created and just finished actually last week. So where did I come from? Saskatchewan, and so just on here, so it's about 1,200 miles between Saskatoon and Madison. I flew this time the last couple times, but I have driven it twice. The last time was in 2019 with a 5-year-old in the car, which was a stupid idea, because in 10 minutes outside of Saskatoon, he asked, are we there yet? But we drove, we were going to Chicago for a conference, but part of the reason was because we wanted to go to Noah's Ark Water Park. And so we stopped there, and so it was fun. So the drive is boring from Saskatoon until about the border with Minnesota, and then it gets a little bit better. And so I come from Saskatchewan, so it's a province that people say it's hard to spell but easy to draw, because it's basically a rectangle. There's about 1.2 million people in Saskatoon, where I'm from, is about 375,000 plus some surrounding communities. The University of Saskatchewan was founded in 1907, and then right now we have about 26,000 undergraduate students and then 4,500 grads. Our college first was the College of Pharmacy, but then in '94 took on a nutrition program because they were too small for themselves, and so there were College of Pharmacy and Nutrition, which you would think that we do a lot of stuff together, but we don't. Well, unfortunately, our students don't get any programming together besides the odd problem-based learning. And then that's just kind of what college and school. So we have all like health science colleges, and they're adding more each time. So I just want to start out with some quotes that I have from the interviews that I did. I'll talk more about the study, but I think that it was good to kind of put these up front, just to kind of show the impact of this research. And so one participant said I already made a list of songs for my funeral. I haven't been to the psychiatric hospital in a while, like it's been a year and a half, so it's really been helping me in that sense. I can participate in my life completely, or more completely. I can officially actually live life because I started this. I don't hate myself anymore, and then I find the thought of killing myself disgusting now. And so these ones kind of stood out to me, and I'll share more with later, but I thought first maybe we should just quickly do a high-level overview of major depressive disorder and then the ketamine. And so, as most people probably in person online know, it's a mood disorder that causes persistent feelings of sadness and loss. And I think in some ways there's a disservice to it by just saying it's sadness and loss of interest, that there's a lot more to it than that. It's the second leading cause of disability worldwide. And around 50% of patients who have had major depressive disorder have had it at least more than once. And so it's a recurring thing for a lot of people, and other people it's a chronic thing. The increased prevalence of it went up by about 40% post-COVID. So, and I was just talking to Paul before, and kind of they've seen some of that as well. And so it leads to increased hospitalizations, disability. There's the economic burden of people not fully participating in society, like so they're not working and not paying into systems and stuff, and the quality of life goes down for people. Partial or non-response, so around 40 to 60% of people respond to traditional oral antidepressants, but then greater than 30% of those will have less than ideal response to 4 courses of antidepressants. And we know with antidepressants that there's many side effects that come with those, and so a lot of people will even stop those before there could potentially be a benefit because they don't like the side effects already. Some reasons for non-response are comorbid disorders, including substance use, can get in the way, so people aren't taking their meds properly in the correct times. Incorrect diagnosis, so maybe they diagnose it as depression, but it's something else. Inadequate dose and duration, and that's what kind of mentioned as far as some people stop it too early, and the dose maybe isn't high enough or it is too high. Non-adherence, again, because of all those side effects, it's common, and I know from personal experience that I've been on 6 different antidepressants, and not one pharmacist has ever counseled me and said you may feel like crap for a while and don't stop taking it because then you won't know. So that's the reason some people with non-adherence. Persistent adverse events, and then unaddressed psychosocial and psychological issues that they have that cause them to fail on the treatment, or other things that are maybe more important in their life and more pressing that they need to look at. Treatment-resistant depression, or what we're starting to see more is called difficult to treat depression, because when you think about treatment-resistant, that would mean that there's nothing's going to help, but really the difficult to treat shows that there is. It's just that something's going to be need to try differently. So it's around 30% of the people who have major depressive disorder have treatment-resistant or difficult to treat. And the definition of that, there's a lot of them, but the most common one is typically that people have failed on 2 or more oral antidepressants. So it doesn't really take into effect if you've done cognitive behavioral therapy or any type of other therapy. It's really looking at oral antidepressants. So just some quick history of ketamine, and so Luke sent me his slides like 10 minutes before I walked back over here, so I didn't really get a chance to look, so he'll correct me if I'm wrong. I think that the dates are right. But in 1962 was when ketamine was first synthesized as an analog of PCP, and I won't try to say any of the drugs, I'm not a pharmacist. I've only played one in different scenarios, so. But they're looking at to see if they could find something that didn't have the hallucinogenic effects. And so in 64 was when human testing began with it. And then we started seeing recreational use of it in the late 70s and started really in California. And then they're starting to see some emerging antidepressant effects on people who are using it for surgeries as an anesthetic, but then also recreationally if people are using it. Similar to maybe what we're seeing now kind of with people with microdosing of LSD and such. And then in 1999, here in the US, ketamine was classified as Schedule III controlled substance, and so that put extra measures on it so that as far as its use. But in 2000 was the first randomized controlled trial, was showing the evidence of rapid antidepressant and anti-suicidal effects. And then we started seeing more emerging data that it may provide benefits for alcohol use disorder. And then it moved on to pain management, especially neuropathic pain. And then we started seeing these IV ketamine clinics here in the States about 10 years ago and on is when we're seeing that. Started out with major depressive disorder, but we're seeing now for a lot more alcohol use disorder, substance use disorder, opioid use disorder. The chronic pain is a big one. And then in March of 2019 was when Spravato or S-ketamine was approved here in the States as a nasal spray. And so I won't argue about the use of that and why, but Luke and I talked about that this morning a bit. So ketamine, as most of you likely know, it's not approved for use outside as an anesthetic, but there's off-label prescribing that physicians are able to do with their clinical expertise. And actually, with my study that I'll talk about, that ethics review of it was, I had to get a full ethics review, and someone said, well, you can't use it, it's not approved for that, but they don't understand the process, so I had to educate them around that. It's demonstrated rapid, robust, and transient antidepressant effects in people with treatment or difficult to treat depression. The effects can be peak within 24 hours and then diminish within a week after that, but we've seen that depends on the person. So some people can get as little as one dose in one session and be fine and never need to use it again, and other people need it quite regularly. The typical routes of administration are IV, intramuscular, intranasal, and then by mouth and rectal as well. And so what we're seeing now is that there's a lot of like Mindbloom and companies like that it's a lot of the oral stuff, but we know that as far as bioavailability, IV is usually the best, but it's also the most resource intensive method. The acute treatment effects, there's dissociation that people can feel, and that's it's a dissociative anesthetic, so you would kind of think, well, of course they're going to feel that, otherwise why would you call it that? Perceptual distortions of things that aren't there that the person thinks is actually there. Hypertension, so your heart rate would, or your blood pressure goes up, the heart rate goes up with a tachycardia and dizziness. And with these two, that's why it's important to monitor when a patient's, especially at first, doing it. And so if someone comes in with hypertension, then obviously you have to watch that their blood pressure doesn't get too high during it, or you have to stop the treatment. And another thing that's not, I didn't listen here, but nausea is another one that goes along with that dizziness, and so ondansetron might be put on with that, or gravel as well. Generally, initial treatment consists of 6 infusions over a 3-week period. That's slowly being modified a bit as more studies are being done, but a lot of clinics are still saying that you do those 6 treatments within 3 weeks. It used to be 2 weeks. So what does it cost? So this is Canadian, but the initial treatment at the one in the clinic that I actually went to in Saskatoon is 3,500 Canadian, so now it's about 2,500 US. And then once that's done, if the psychiatrist sees the patient and they feel that they still need, or that they might need in the future, then they might need a maintenance dose. And so those maintenance sessions are about 525 Canadian, so 365 US. And then that tends to be at whatever the intervals are that the psychiatrist feels it is best, and the patient, because obviously the patient would know, but they don't want to do it too often because we still don't know a lot of the long-term effects of ketamine. And what does it look like? Well, according to Microsoft Copilot, this is what it looks like. I don't know why all these bags are there. What I've experienced and seen, there's one bag and they might put something into the bag or into that one line, but it has some work to do, and this is the other one that it created for me, is that someone's just sitting there and looking very sad, so maybe because of the depression. But this is the clinic I went to, and surprise, that's me. And so it depends on the clinic, so everything's different. If you've seen the treatment room that I was fortunate to just see here, that it is a lot more of a comfortable feeling, whereas this one that I'm in and some other people are quite sterile. And the chair that you're in, or bed, actually, I've thankfully never had chemotherapy, but people call it a chemo chair. And so some of those things can throw people off, as we'll maybe see. And so as far as ketamine, what's the headlines and promotional communications that we see out there? And so we have a lot of clinics that are doing it for profit, and so in Canada we don't have yet where people can get it through the mail, but here you can, and get virtual ones. There's a Beyond Marketing that says, how can you overcome negative press? And so it knows that there's some negative press, so for organizations that are promoting this, they want to help. And then the clinics emerge, and some are going bust, but why are they going bust? Is it because it doesn't work, or is it just because of the cost that it involves and that people aren't able to pay for it? Therapy for men is a Wild West, because there wasn't a lot of evidence, but again, this one was from last year, but a lot has changed, and even that year, it's quite quickly. Again, some clinics stray from the science and hype its benefits, and I'll talk a little bit about on that in a bit here. When Matthew Perry died a year and a half ago now, it was highlighted that he was on ketamine. Why did he have ketamine? And he had it himself, so it wasn't the ketamine himself, he wasn't being supervised, so the fact that he could inject it himself and then sit in the hot tub I don't think that anyone would recommend that you do that with any drug that you could have hallucinations and such with, or in this case actually knock you out because it's an anesthetic. Mind blown, so I'm not making fun of or questioning anything, but this one was on their front page. It says, free yourself from anxiety and depression with ketamine. So it gives false hope, I think, to a lot of people that you can free yourself completely from it. But then it says 89% of patients in their ever study found it a relief. So to me, relief is quite different from freeing yourself from it. So there's that false hope maybe. So yes, they're linking a study to it, but the study doesn't match what they're kind of in the larger letters. FDA warns about the compounded risks. Michigan had kind of severe depression, but major questions remain. And then we see that in the news lately is a lot more about Elon and his use of ketamine and kind of the negative connotations that go with that, like calling him ketamine boy and stuff that I've seen, so that maybe is a negative perception on what it's like if people don't care for what he's doing and what he stands for. Disturbing rise of ketamine abuse, and so again, it's being used, but ketamine recreational has been used, as we saw, since the late 70s, so it's not anything new, it's just that it's getting more attention now. And it's kind of like looking at opioids and saying that people abuse them, but then it also puts a stigma on people who use them legitimately. Tech executives are back on track with the psychedelic slumber parties. There was a drag queen in the UK that died after taking ketamine, and again, the highlight or the heading is really a clickbait in some ways, in that they want you to read this story, because if it just says that they did use ketamine and it may have contributed, that's not going to get the same as like they died after taking it. In Canada, there's more clinics kind of opening up, and so while we have in Canada, we have public healthcare system, but that's only for inpatient medically necessary things, and so things like ketamine traditionally haven't been covered for anyone. There's a few small exceptions, but for the most part, you have to pay out of pocket. In Halifax and Nova Scotia, the province of Nova Scotia, they're raising funds for ketamine treatment programs, so they're starting to see benefits, so they want to actually have it within a hospital environment. And then this latest one from Harvard is kind of like, how does it work? Because that's one of the questions is, it was originally developed for one thing, but we know a lot of drugs are used for different indications, but how does it actually work and why do you have to keep using it? That's still a question out there. So information, so why did I kind of think about doing this study was information that's currently available on IV ketamine, and really any type of ketamine therapy is potential consumers is limited. Even calling them consumers, people would say in some instances is wrong because they should be seen as a patient. What is currently available tends to be clinical in nature and most often behind paywalls. So unless you're fortunate like us in the room and maybe many online, is that you can't access those articles unless you want to pay $60 and up per access. And then for someone like me who is not a clinician, trying to understand some of the jargon in there is quite difficult. And then what is on clinic sites, so these for-profit clinics, tends to be very positive. Like we saw the Mind Bloom ones, that it tends to be more positive and that the negative aspects are not talked about. And so for me, I first asked a colleague, the psych pharmacy colleague that I had at the time, he's since retired, about it, and he said it will never, about 14, 15 years ago, he said, it'll never be, that's too resource intensive. And so there wasn't a lot of information out there for this, and I have access to information. So I'm fortunate enough to work at a university that has access to any journal in the world, have colleagues who know a lot more about this than me, and it was still hard for me to find information. So we really sought to understand patient experiences leading up to and while receiving. So how did they come about receiving it? So why did they get this? Was it something that was suggested to them, or did they find it out themselves? Because again, there wasn't a lot out there. So the studies that have been out there tend to be parts of clinical trials, and sometime in a clinical setting, but we looked at it as in, if you want to call it, real world setting, and so there wasn't one prescribed dose for people and experience. And so we just had this published, I think it was about a month ago. And so for this, we worked with the one clinic in Saskatoon that provides a Linden Medical Center, and so they agreed to send out a request to participate to all their patients in their database who had at least one session with them. What we found is that just because they had it with them doesn't mean that that's the only place. So I had people that came to the States to do it, and in other cities outside of Saskatoon. So we conducted semi-structured interviews on Zoom with 20 self-identified people received for treatment-resistant depression. So they could have comorbid conditions. So a lot of people had anxiety, had chronic pain and stuff, but the primary reason they were using it was for their depression. And to note is that we thought this was going to be a hard to reach population, just based on evidence, and within 24 hours we had 20 people sign up to participate. And then I developed a questionnaire because I thought, well, some of these people said, well, is there any way I can share information? So I created a questionnaire, got the clinic to send it out, but they, instead of putting all the email addresses in the blind carbon copy field, they put it in the carbon copy field. And so there was a privacy breach and the study was halted. And I got in trouble from our ethics board, and so it was a big thing, and very unfortunate because a lot of those people wanted to share their stories as well. So we interpreted things, looked at the various aspects of the experience, such as the effectiveness, the clinic experience, and any input that they had around theirs and what they wish they would have had done or what they'd like people to know moving forward. So of those 20 people I interviewed, 19 returned a transcript or release form, which again, I was kind of shocked about that many. I followed up a couple times with the person who didn't, but then you have to stop after a while. And you hope they just didn't want to participate, but hopefully it's not bad reasons. Interviews range from 25 minutes to 123 minutes. Most have just over an hour. The one that was 123 minutes, it would have went probably 5 or 6 hours if I wouldn't have cut it off. They just wanted to really talk and share their story and experience, and this person still checks in with me, sends me stuff all the time, asks about updates, and so it's quite heartwarming when you know that you affected someone, that they want to keep reaching out and that they say that you've helped them. So after the coding and analyzing the transcripts, we found 3 primary themes. So the effects experienced during the ketamine, the effects and outcomes of the ketamine treatment, so the kind of the after things, and then the contributors to ketamine experience and their outcomes. And so the first is the cognitive effects, and that really looked at their awareness of surroundings, a decreased inhibition, dissociated, disoriented inability to think, and skewed perception of time. So people talked about how, so the typical session is that from once they start the drip to when the drip's done is 40 minutes. But some people felt that it was hours that they were in there. And it takes you a little bit of time to come out, but for the most part, under an hour, you're kind of back to reality. Behavioral effects included things like, oh, I just noticed, sorry, the U in Canada, we put U in behavior and favor and all neighborhood and all that stuff. So hopefully you can still understand what it means. Crying, laughing, talking. These people, so I don't know if it's appropriate, but I bring in my own story too, is that there's no way I could talk. Once I got up to high enough dose, there's no way I could talk. But there are some people who do therapy throughout, so the ketamine assisted therapy, that they have a counselor with them throughout it. And I heard from these people too that they would talk the whole time. One person talked about how they don't shut up the entire time that the ketamine's going, and I don't know how that happens, but it does. One that wasn't part of the study, but a personal experience, is that the treatment rooms are relatively close, and the person in the room next to me, I found it was female, once she started yelling and screaming that she wants to F and die and kill me now. And you know, so those type of things can come out and very jarring. I said if it was the first session I went in and someone was doing that, I would have walked out of the clinic instantly. But the fact that I saw it is, even though the person might be thinking they're going through hell at that time, that it was actually going to become beneficial for them as their breakthrough. And I found out later through other people that this was a breakout session for the person. So it's, you know, someone else from the outside may think that this is not the right thing to do, but the ends justify the means. We'll see. Emotional effects, so anxiety and panic. That people can feel panic because you lose control in a lot of ways, and so a lot of times in these psychedelic experiences, that your cognitive processes are impaired quite heavily, and so you have to feel comfortable in the environment you're in. So at this clinic, I think most clinics, but in Saskatchewan, the stipulation is that there has to be an anesthesiologist or emergency doc present, and then there has to be a nurse present too. And so that's kind of tries, obviously if there's a medical incident, they can help, but it's also about being able to reassure people that it's okay and that you're being monitored. So, and I know personally that I have hypertension, hopefully not anymore, but that my heart rate would go up, but they said it was okay, the level that it was going up to. But if someone who wasn't more physically active, they wouldn't stop the treatment. The physiological effects, so body unawareness, you be feeling cold, decreased respiratory rate, groggy, those type of things can, I know that for me it was that when you get to high enough dose, you're not really moving your arms or anything. Like you could tell that the whole anesthetic part was kind of maybe setting in a bit. The psychological effect of the break from reality that people had, realization, altered outlook on life, and that we'll kind of talk about in a bit here. And then ketamine-induced perceptions, so kaleidoscope shapes, colors, and stuff that people saw. So the psychological relief from trauma people saw, so that peace with past, so people kind of revisited some things, and that they were avoiding, and sometimes maybe even things come up that they didn't realize they had experienced because their brains in a protective manner kind of force it out. I don't know if I have a quote on it, but one talked about the fact that she lost a couple babies. I didn't ask in what case or sense, but it allowed her peace with that and kind of a goodbye, and so that's powerful. Feelings of purpose, so a renewed sense of purpose. People did have distressing moments, experiences, but they did at the same time realize that those negative experiences were beneficial for them overall. And then a break from reality. So a lot of people talked about the fact that they can escape reality by going there, like so they get rid of or away from their depression at the time. I know some people talked about the fact that if they have chronic pain, that's the time that they actually don't feel any pain, and so it gives them a break from that constant burden. The perception, the visuals, some people saw familiar faces and relived things, so people had lost in the past or traumatic experiences. The floating sensation as far as sensory, enhanced music perception. So we've heard in different psychedelic things too, people talk about how you can kind of see the music and feel it, and that it really impacts what you're listening to, and then participants detach from their bodies. So that whole mind-body break that people experienced, that they were no longer one and the same. It was kind of, and for me, I saw kaleidoscopy type of images, but I never saw any discernible images, and I never saw people or relived anything, but it always felt like my head was completely separate, and it's a big head, but, and it kind of felt sometimes like you're almost like, I put my head on a roller coaster and it went around, and so you can see why people get nauseous is because it feels like you're moving all over the place, but you're not actually moving anywhere. So here are a few of the quotes that I just included from this theme. Is like the one he talked about that his dad had just died, and thinking, is his dad there? Is his mom there? He wasn't sure where he was, thought that he was dead for a little bit. And then he completely experienced the detachment. Another one talked about second treatment was horrible. I had a lot of weird visions of war and death. The rest of them were good, really, really positive after that. Fantastic learning experience, so able to process what I was thinking about and make sense of things, and so kind of that noise got put away and they were able to concentrate on things. So when trauma kind of playing in front of me, so this is, I lost 2 babies and I saw them, it was just weird, a piece about watching it all. Should feel sad, but I felt like I was floating, everything was going to be okay. And it was hard doing these interviews and not emotionally, like I'm not a crier, except for the odd time for Survivor, I don't know why, but I'm not, but like it's very hard to like keep your composure while you're talking to these people and they're talking about life-changing experiences. And then the second theme was just looking at the effects and outcomes of ketamine treatment. So a neutral, so a couple people did not experience any benefit because they, a high stress period, some of them talked about inability to rest and just relax, maybe the inappropriate dose, so maybe it was too high or too low. Others impactful is like improved moods, balance their baseline, so it was almost like their cup was reduced, it wasn't as full, so they were able to cope with things a little bit better. Acute treatment, so we also saw the family and friend perceptions is that people tended to not necessarily see changes in themselves, but their family and loved ones did see that change first. And then a big one that a lot talked about who did have suicidal ideation was that it reduced that chance or eliminated it completely. So the neutral, so the negligible effects, it not really much. The high stress, lack of integration. So I'd say 75% of these people did not do integration with a therapist either before, during, or after. And so some of them talked about the fact that they thought that contributed to the neutral effects. So they may try differently the next time they did it. But again, that they would continue recommending it for people. So even though they didn't see benefit, they know that it has the beneficial effects. The improved mood that I talked about, daily functioning, so they increased motivation, improved relationships, so they were actually present with people and not kind of zombies. The altered outlook on life, that they have purpose, because a lot of these people talked about the fact that they didn't have a sense of purpose in life anymore. They didn't know why they were there and what the reason why they thought that they were a burden on people. And then that reduces sociality. So some of the quotes here is that they're not doing integration, not resting, that they would fall asleep during the session. So to me, that's the fact that you fall asleep is probably that it was too high of a dose. Found no results, really high stress time. I felt like I wasn't my best. Once that I had one of those lovely intrusive suicidal ideations come along, the ones where I was driving, I was like, oh, I could just veer off the bridge and into the water, right? Immediately I had a response, no, I'm finally happy that can't happen. They're planning for their future now. It wasn't a thing they ever wanted to do. So not just the fact that they didn't do it, but they never wanted to do that. Planning to be around longer, planning for a future in life, that's pretty foreign, and they're okay with it now, which some people can struggle with the fact that it's changed so rapidly that they all of a sudden have a different outlook. It was easier getting out of bed, less of a challenge for them to shower, help around the house. It wasn't constantly like sitting on the couch, actually could become a functioning member of the household. And so talk about the relief of that burden, not just on themselves, but on their loved ones. And then they just kind of talked about, this one just talked about, just doesn't feel real for the rest of the day. So even though they're done, and ketamine's cleared pretty quickly, but they talked about the fact that they just didn't feel normal for the rest of the day. That was kind of foggy and fuzzy. And then the third theme is the psychosocial importance of the treatment, the environmental impacts of the physical and the experiential, and then barriers. So the psychosocial is like the intention setting, and a lot of people talked about, again, not only did they not have the integration, but they didn't set a kind of intention of what they wanted to experience, and that has been shown to be quite important for people. The psychotherapy, again, that plays a significant role for a lot of people. The fact that they had someone in there or had someone that they talked to before and after. A few talked about the importance of getting the therapist would tell them about what to expect and what you may or may not experience, and open-mindedness about releasing control. So one of the things is that as humans, you want some control, and when you're doing ketamine or other psychedelic therapy, that you have to kind of quit trying to resist where it's going, and you just have to lean into it, which can be quite nerve-wracking. So I know for me that it was, I would think, is this my new reality? Is like this what is reality? And so you kind of get a little panicky for that as well. Oh yeah, thank you. And the clinic environment, so the supportive staff really helped people. So when the elevator opens, whatever clinic is, the fact that someone's there smiling and happy to see you, and that makes a big difference, because it's setting you up for more likely for success. The session routines, so a lot of people talk about what they like to do. So for me personally, it was, I'd have to have a music, I'd have to have an eye mask, and I'd have to have, with the music, I put in my AirPods with the noise canceling, so it blocked out everything. But at the beginning, that wasn't something that I wanted to do, because it was afraid that released control somewhat. But people did talk about the fact that they'd be deep in a session, and then when the IV pump would stop after 4 minutes, it would give a beep, and that would take them out too quick. And then the physical characteristics. So they wanted, from what you saw those pictures, a less sterile environment and more comfortable, like you would see the treatment room here or a lot of other places. And the people who had been to other clinics talked about the fact that, it's not the best. Some people go to a smaller hospital that you don't have a room to yourself, it's just 3 hospital beds beside each other with like fluorescent lights on and stuff, and so that's not a good environment in any way. The barriers though, big one was the high cost, the significant barriers. So a lot of people talked about how they wanted to continue to do but couldn't anymore. One talked that they're a veteran and that they wouldn't have been able to afford it, and it took them 12 or 13 sessions just to see any benefit, so they would have stopped after 6. And others that they can only do it once every 3 months because that's all they can afford. Accessibility, so there's the financial, but then there was also access. So in a geographical region, Saskatoon was the only clinic that someone could get into. So there's one in a city about an hour and a half away from Saskatoon, but was started by kind of under the radar by a psychiatrist, and then he suddenly passed away, and so all these people were like, where's my therapy? So they grandfathered people in, but no one else knew was getting in. So we actually see people there. So there's this city called Winnipeg. If you watch The Office, they were in Winnipeg once. But that's an 8-hour drive to Saskatoon, and some people are driving that far in order to get it. So the accessibility limit application, and then the cost. So when you do that, you have to travel. You're not supposed to drive yourself, so then that's someone else that's coming with you. And a lot of the times you don't really feel like driving in a car for hours, so you tend to stay overnight as well. And then there's the stigma as well, that the bias and misconception about ketamine, because people think is it Special K and the party drug. And so people think that that's the only reason that you'd use it. Healthcare professionals lack the knowledge and support. So that was a barrier. So some of these people talked about that they asked their family or general practitioner about, and they were not given any information because either a stigma or they just didn't know any information about it. And then social stigma around coworkers and others and impacted their willingness. So they didn't want to see as like drug seeking. And so they didn't, they didn't pursue that treatment for a long time because they thought about the social stigma around it. And one person who's a professional, a medical professional that I interviewed, her coworkers did find out that she had done it and reported it to the regulator, that because then she wasn't fit, so she got suspended for, which is completely ridiculous, but that's kind of some of the things that people are up against. So there's kind of a few more quotes. It's just the environment was sterile, it's stressful, it's nerve inducing, watching you every 10 minutes, taking your vitals. So at this clinic, I think most clinics, every 10 minutes the blood pressure cuff turns on, so that can throw you off quite a bit. It'd be nice if you kind of just forget about the medical part. More comforting, it's so expensive, can't afford to keep it up. I feel like I'm back to square one. And so that's, people talk to as well, that I know that this can help, but it's out of reach for me. And then you have to think about, so one of the people talked about how they had been in the psychiatric hospital for 142 days before trying, so that's thousands of dollars a day, plus they're not contributing to the work environment, not paying taxes, so there's a lot of hundreds of thousands of dollars, and you know, they're getting this treatment. Yeah, it seems expensive, but relatively it's not. They wish everyone had access to it. You see the lives are lost and all because of a cost. How much does it cost every time you go to an ER? How many times to do that? So a lot of people talk about they needed help and they reached out and would go to emergency, and so that way they could see a psychiatrist quicker. The family doctor was kind of hesitant, wasn't informed, was upsetting to them. And then it's medically, just like diabetes or insulin, so people are saying it should be covered. And so we know that the cost of the drug itself is minimal. It's the professionals and the environment itself. So findings that provide a broad pragmatic understanding of the effects of it to these people. It's profound to most, improving mood, daily functioning, and reducing suicidality, which was great. The accessibility is an issue. They need the supportive environment, so the right people have to be working there in order for that, so it can't just be anyone who works there. And I know for myself, it was some of the nurses that I had, you'd ask them a question and they'd respond with another question. And so they didn't seem like they were actually educated on the treatment very much. And then that intention setting and the treatment setting is very important to these people. Some future research to think about would be like predictors of response. So how come people respond differently? So I talked to some people, one person had 3 sessions in total and has never had a sign of depression in years since, and other people need it every 2 weeks. So how come we're so different with that? Maybe it's why there's been difficulty with migraine meds, is that people are very different on what they need. Cost effectiveness, again, more needs to be done around showing the cost effectiveness, and not just the cost of the treatment, but what it prevents down the road, and the educational materials around setting the realistic expectations, and not that it's all going to be great. For me, the only reason I felt comfortable going in a sense, is that a friend's husband had done it, and so he told me and sent me a picture of him, and so I saw, oh, okay, I'm glad you showed me that environment, because I'd only seen 60 Minutes. Yeah, I'm an old guy who watches 60 Minutes still, but you'd see some of those in, like, it's very kind of like the treatment room here, but and so if I wouldn't have, I've been shocked with, like, come in there and they're kind of just talking about, like, you'll see anesthesiologist first, then you talk with the nurse, and then you go into the treatment room, and those things help a lot. So one of the things I think that was put on the flyer is, like, what's the role for pharmacists? And so most community pharmacists know very little about ketamine in general, because if it is used, it's an inpatient thing, and so very few will, they might be just one of those ones that's brushed over in their pharmacotherapeutics course. But it is being treated, used for, like I've mentioned earlier, chronic pain, PTSD. I mentioned that one was a pharmacist or a healthcare professional, but I just outed that they're a pharmacist maybe. Compounding pharmacists may have slightly better understanding, and it's off-label use. And so if you're prescribed a lozenge, or I hate this word, troche, but those, it tends to be compounded. It's not, the clinics don't have those typically, and so they may know a little bit more, but I know for me, I did get prescribed that, and the information that I was given by the pharmacist was the same information I found myself before. Drug interactions, impact on health, legal considerations, and just being a source are a few examples of roles that pharmacists could play. So even if this or any other psychedelic, the traditional psychedelics, they think that it's not right that people are doing this. Well, the fact are, people are, so you should know, you're their expert, that they should be able to go to and say, I'm going to be taking this, is there anything I should do? Should I stop my hypertension meds, or should I increase it? What about my antidepressant? Those are things that really need to be talked about, and you can't just gloss over it. It's similar to what we saw with cannabis, and that it's one of those other things that people need to be aware of, especially, it didn't really come to the forefront until Canada legalized it recreationally in 2018, so it was slapped in everyone's face whether they wanted to or not. Before that, it was strictly medical. And then one of the things that we wanted to do was create some type of information. We didn't know how it was going to look, but we decided that now we were going to create a patient information booklet, and it was to put in lay people language, freely available and objective. So we provide sources in it, and we have, as I'll show you through it, that we included quotes from people about that as well. So we just finished it last week. And so the first thing up front, besides the cover page, is the mental health is health. And so if there's people outside and are struggling, here's how you can reach out online right away. And so this can be easily adapted to other environments. We get into the history of it as well, and just what it's used for and what it was originally developed for. Talked about, like, the fact that 3 of every 10 are difficult to treat depression. So giving people kind of hope that you're not the only one, that there is other people struggling with this kind of, for that misery loves company type of thing, is that to know that you're not alone helps a lot of people. What is difficult to treat depression, so kind of goes into it, and what's the difference from treatment resistant, and kind of just to kind of say that, you know, the two are just different terms of meaning the same thing. What do you mean ketamine? So we had a student last, like in the fall, do this stuff for us. And so there's no way it works, so some questions that people might have around, well, why would it work? It's an anesthetic, or I heard it's only used as a horse tranquilizer. You know, does it cure depression? And so again, there's no cure, so no, it doesn't. Is only available as an IV infusion, so tell people that no, there's other methods that you can get IV or ketamine treatment, sorry. Isn't it dangerous and illegal? So talk about the legal aspects of it. Brain damage, so these are common questions that people may have, what to expect. So talks about finding a trustworthy clinic before the treatment, what you should do. So again, the things that most people will want is like music, so creating a playlist, kind of the sleep mask and those things that help people better prepare. I know for me that the first time I went in, I didn't put an eye mask because I thought I'd lose control, and it was freaky. Like when I would see these documentaries, there's things about people doing this and putting on headphones and an eye mask, and I'm like, there's no way I could do that stuff. And so I didn't bring it. So then after that first time, I realized I don't want to use the Bluetooth speaker within the room. I want to use my own to cancel out. And maybe they don't like Pink Floyd like I do. This one, what can I expect to experience during the session? Visual and auditory perceptions, the physical sensations. Again, that if you don't know this, so I talked to one friend who did this before. She actually tried for long COVID, but I think she has depression too, but talked about nausea and how she threw up in her mask. And so for me, it was when they said, do you want anti-nausea medicine? I'm like, yep. And I would have said no, because usually I didn't get nauseous, but I did right away. What thoughts and feelings you might have, the out-of-body experience that you could have. And again, we're inputting some of the quotes from people. If I was to adapt this to American, again, I'd have to take the U's out of color and stuff. And then out-of-body experiences, that not everyone experiences mild life-threatening effects. So this came about because for me, I felt like I was being, I don't know if ripped off is the right term to say, but I felt like I wasn't getting my money's worth because I wasn't having mind-altering experiences, and I wasn't reliving things or seeing things. And I realized that the spectrum is from people who saw absolutely nothing, they just saw everything the same way and talked throughout it, to people who were reliving traumatic experiences or thought that they, as soon as they're done, they're going to go fight in Ukraine war. So there was quite a variety, and so it kind of helped me too, and to realize that like, no, it's different for everyone. And then this one, what can I expect immediately after? And talk about, again, we can't cover everything, but it's a good starting place and does provide references. Planning a safe ride home. Some clinics will say don't drive for 2 to 3 hours. Some say until you've had a full night's rest. Take it easy for the rest of the day is what we kind of wanted to put out there, just so people, like, and some people talk about, you know, that they either want to sleep the rest of the day, or they're energetic the rest of the day, or they have this absolutely monstrous appetite that they want to just eat like crazy. The long-term effects of it, so talks about your mood and motivation, impact on relationships, and so they're talking about how that could impact things. More of this is just suicidal thoughts, neutral impacts. So again, that we thought it was important to show that it's not always positive, it can be neutral. And we didn't put in, like one person I interviewed did say how the first session they blew out her vein, and they realized that it was likely that the pump was too quick, like I think they put it at 30 minutes instead of 40 minutes, and so her vein didn't handle it, and it wrecked her whole experience. Keeping it real, and kind of just shows the negative and positive aspects that you should consider with that. In this booklet, hopefully people will have the ability to bring it into their healthcare professional maybe too, and say, I'm thinking about this, what do you think? Here's some information. Because I know for me personally, with my family physician, I went in and asked, and he's like, I don't really know anything about, because again, they're a general practitioner in the community, they're not in hospital. And that's even with my GP, his first 2-year residency, he did ER. So he was doing a merge residency and he still didn't know very much about it. So we just finalized, like I said, the Linden Medical Center already said that they're gonna put it up on their website, because it's a neutral, objective, we hope unbiased information, but then these clinics don't have to do that for themselves, and it's free, like we're not charging anyone for it. And like I said, it's currently for Canadian audience broadly, but we can adapt it if anyone wanted to use it as well. So just a few takeaways is that the need for clear expectations, supportive settings, and it helps if you have a supportive family or loved ones that, and so most people talked about how either their spouse or their parents were the only ones initially knew about this because they were afraid of the stigma, but that once people started seeing a difference, they're like, what's different about you? And so then they felt more comfortable talking about it. And a lot of these people are very big advocates for it, and they said, I know for ethics you can't say my name, but please, if you feel you need to, say my name or send someone, they can email me. A patient perception of acute and antidepressant effects is individualized, and so that differs from what's more reported in the quantitative data. So if you're doing just a survey, you might not understand that as much. Additional research should look at the patient characteristics, cost effectiveness, and effectiveness of maintenance infusions too, and at what point, or should you just stop if they're not seeing any more benefit. And so there's highlighted kind of gaps in care which seem to impact patient outcomes. And so even if the clinicians providing this could experience a little more, and with psychedelics in general, there's that argument that maybe the people who are administering them or providing therapy should also experience it themselves. And some against that argue that, well, I don't take chemo meds myself and stuff, but that it's a different experience when it's kind of that mind altering as well. And then so the 4 people who are instrumental in this work is my colleague Caitlin, who is the psych pharmacist, and then the 3 directed research study students that we have as well. And then thanks to IHP and Luca, for the invitation and for allowing me to speak. And hopefully I didn't put too many people asleep with my voice. It was like ketamine inducing. Maybe you'll put me on at the beginning of your sessions if you want to feel more relaxed or something. So yeah, so I can take questions here or online, I guess.